And this is before, I like to say, even the GLPs came onto the scene. So I got into this even before it was cool. And, for the first time, I came across a group of people that really took this problem seriously. And I felt like during our training, there was so much nihilism that people were like, oh, you can't do anything about this. Let's treat the diabetes and hypertension. But even before, again, these medicines, it was like this field incorporated evidence-based medicine with, the scientific methods, studying nutrition, physical activity, sleep, and also combining mindfulness, therapy, coaching. I since became certified in mindfulness-based stress reduction. I incorporate a lot of that. But really, because this is related to everything in our lives and really a function of our bodies in this food environment, when I treat patients, I say nothing's off the table and really dealing with patients in a comprehensive and holistic way. And just the last thing I want to say, like my job as a hospitalist, you see people in the hospital with decades of, the disease processes of the elevated blood sugars or elevated blood pressure, and you see the resulting strokes, heart attacks, kidney failures. But doing this work, and really is, I think, the ultimate preventative medicine, because you're preventing so many years of, not just like lost life, but just quality of life, and also how people see themselves and relate to the world. So I describe this as the most gratifying thing I've ever done, and I'm really grateful that I can share some of my experiences and some of the education to help spread some of this teaching and ways of thinking and treating our patients. So with that, I'll get into this talk. Just to, it kind of mirrors what I'm saying. Obesity affects every single organ system. So I think that with, in the last few years, especially, this new paradigm in medicine has become more prevalent. I do think, though, that we're all very conditioned to what I call the willpower narrative. And we still think, even a lot of us in healthcare think that, this is a function of our willpower or discipline or strength or something like that. And yet, it clearly, given 70% of us struggle and all the other things I'm going to talk about, it really isn't. And I think even medically, we can see how this is a disease process that affects everything from migraines to pseudotumor cerebri, of course, dyslipidemia, fatty liver disease. And of course, this is the number one cause of fatty liver disease, surpassing alcohol. We have diabetes, osteoarthritis, gout, of course, cardiovascular disease, hypertension, GERD, polycystic ovarian syndrome. It's really interesting, having getting people to lose weight really drastically improves their fertility. OSA, depression. On the slide isn't even the risk of cancer. So it's, there's a lot of evidence and, like, I think studies basically proven that because of adipocytes, extra insulin-like growth factor or extra, like, excess estrogen, you have an increased risk from diseases such as colon cancer, ovarian cancer, uterine cancer, from obesity. And we've actually seen this with studies with people who've gone gastric bypass. They actually have less risk of certain malignancies compared to people who didn't. So this is 100% full stop a disease, and it's actually the upstream of many other diseases that we treat regularly. So I'm going to move on to the next slide. And I apologize, this slide is kind of delayed a little bit. Sorry, guys, I'm trying to get to the next slide. It's not working. Sorry, if any of the admins can help. Oh, there we go. Okay. Okay. So basically, this slide just shows, the prevalence, kind of going on what I was talking about, how all these conditions have the concurrent comorbidities with obesity, which was, the pretest question. But 75 patients with hypertension struggle with weight. 38 to 88% with PCOS, 50, 75 with fatty liver disease, 90% with diabetes, 45% with OSA, 72% GERD, 60% with osteoarthritis, 60 to 70% with dyslipidemia. So you've seen these varied disease processes that affect our bodies. Weight, obesity and excess weight is a strong underlying factor in a lot of these conditions. Okay, here we go. So this is talking specifically about diabetes. Just waiting for the charts to come. Okay. And according to this study, you could see the population prevalence, with the percentage of people, percentage of diabetics with obesity. And you can see how, as the years keep going, this is only increasing. And now, we're up to the 78.8% on this study. The other study showed 90%, but still a significant population of our diabetics struggle with weight, and this shows the underlying, association between excess weight and insulin resistance. So answering the pretest question, which of the following comorbidities is most commonly experienced among patients with obesity? And the answer to that would be diabetes, as shown in the previous slides. But really, it points to, when our patients come into our practice, we definitely put them on metformin, start them on insulin, which unfortunately leads to even more weight gain. But often, at least in the paradigm of the last few decades, we don't treat the underlying condition, which is the weight. And it makes sense. We, in the past, didn't have good tools or a good way of thinking about it. And really, to be fair, we get absolutely zero training in medical school and residency about it. But it's just so much potential to help so many patients if we can, think of this in a much more effective way. Okay. So so any amount of weight loss is really helpful in so many conditions. And this is just empirically, we see 3 to 10% helps with diabetes, 5 to 15 with hypertension, 3 to 15 with dyslipidemia and hyperglycemia, 5 to 10 with osteoarthritis, stress incontinence, GERD, PCOS. I've had patients, just a few pounds of weight loss has dramatically affected their joints. We can also think of obesity actually as a low-grade inflammatory state. So conditions as varied as rheumatoid arthritis can be helped by losing weight, not to mention the biomechanical effects of weight on people's joints, back pain, all the things we see in a standard internal medicine process, in internal medicine clinic. Interestingly, when we actually have fat deposition in our bodies, after initially, as we gain more and more weight, initially our subcutaneous layers are filled, and then afterwards, the weight gets deposited within our visceral organs, which of course we know is the most dangerous weight gain. However, when we lose weight, that's also the first weight that comes off. So when we treat people for weight loss, oftentimes we may not see it initially, our patients may not see it, but that's doing dramatic things for their health, because as we know, as fat deposition in people's heart, increased risk of atrial fibrillation or pancreas and diabetes, and of course, fatty liver disease. So just really focusing on this and really, thinking about this as a disease process is just really, really helpful, can really significantly impact our patients' lives. So in terms of post-test question number 2, your 44-year-old patient with a BMI of 36 presents to the clinic for an annual visit. She has a history of dyslipidemia and hypertension. What percentage of weight loss is needed to see a therapeutic benefit in our hypertension? And then we see B, at least 5% with a max benefit of greater than 15%. I just want to go back to the previous slide real quick. I apologize. The slide is deck isn't going. Okay. Um, I just wanted to talk about just real quick dyslipidemia. The things I see regularly when I treat patients. Um, Insulin resistance and triglycerides and HDL are dramatically improved right away, right? People's A1C drops very fast. Measurements such as LDL are a little bit more resistant to weight loss, but some of these other metrics, it's really amazing, especially with blood sugars and A1C. It's just the effect of weight loss on these variables is just so dramatic. So how do we measure obesity? How do we define it, right? The traditional definition, the insurance definition is a BMI greater than 30 is what we call class 1, class 2 obesity, and overweight we define as 25 to 29. Just as a reminder, what is BMI? The whole BMI, all it is weight corrected for height. And the point of it is when you take a population, how do you compare health metrics between a population when people are different heights? Use this formula, you put everyone on the same line. I know there's a lot of people down on this measurement. I think it's not like with all of the tests we do, nothing is like an end all be all. You take multiple points of data. But of course, there's a lot of deficits, when talking about BMI. One thing is that it's different for different racial and ethnic groups. People like myself who are of Indian descent have a much crueler BMI, which is a BMI over 23 is considered overweight and 28 is obese. However, this is even much more complicated at an individual level because, Arnold Schwarzenegger or some of these amazing Olympic athletes we've been seeing in the last few weeks may have a BMI over 25, but of course they have increased muscle mass. So in my clinic personally, I'm fortunate enough to have a body composition machine, which is a body impedance machine, which is a low level electric current that goes to your body that measures the amount of fat and muscle. The gold standard is a DEXA, which is an X-ray machine, but I think the future will be more and more body composition. Of course, right now it's not really available to a lot of people, but that will actually help determine a lot of our treatment goals. Another metric that we use is waist circumference. Um, okay, I apologize for this. It's a little bit. I'm trying to move this slide. Okay, so this slide, basically says the same thing, right? BMI is just kind of all of you. It's every part of you, which includes fat, but also muscle mass, bones, and everything like your soft tissue, your subcutaneous, all of that. So really, when we're tracking different measurements of how people are doing, a lot of times people may not see the gains, with the weight loss, but I ask them, like the jeans test, right? Are your jeans fitting better? Are your clothes fitting better? Especially the patients I do virtually who can't do body composition. There's other metrics that you can kind of ascertain to show that people are making some progress. And of course, I would say that to my patients, if you lose like 5 pounds of muscle, but gain 5 pounds of fat, but gain 5 pounds of muscle, you're the same weight, but that's everything we want in the universe, right? So that's why I think, just like with any test, we don't use one data point to determine what's going on. Like my training as an internal medicine doctor and, working as a hospitalist, this is very clear that you have to take the whole picture into account when treating our patients. Okay. So another metric that we use is waist circumference. Waist circumference, of course, I think we've heard of is that is very associated with increased mortality. And these studies show hazard ratios when compared to waist circumference in men and women and comparing smokers, never smokers. But as you can see, all the lines go up as our waist circumference increases. So we can measure waist circumference using these measurements with men, who have a high waist circumference compared to a lower waist circumference at, a class 1, class 2 obesity ranges, um, or sorry, overweight and class 1 obesity ranges, you could see that there's a differentiation you can get with patients who are overweight but have a higher, have a higher waist circumference. They actually have a higher hazard ratio for mortality compared to, those with less. And sometimes, patient providers may feel a little bit awkward how to measure it. I think, kind of more informal tests are how patients are, again, the clothes tests, if their clothes are fitting, correctly, or sorry, if their clothes are like, I just call it the jeans test. That's, I think, the best test to determine if, you know, people are losing weight or achieving some of their metrics. But this is just kind of a more formal way to do it. You start with the iliac crest, and it's you put a horizontal tape that goes around, their abdomen. And so these are the formal way to do it. I personally don't do this as much, but because I have the body composition, but it is another way to kind of help stratify some of our patients. So now we're going to go into a case study of MS. She's a 42-year-old woman, comes into our office for our annual checkup. As you can see, her BMI is 36, blood pressure 130 over 80, heart rate of 90. So we sent out a blood work, set up a telehealth visit to discuss any findings. And we see her labs. So she has glucose that's in the pre-diabetes range, as is the A1C. We have an LDL 112 and an HDL 50, triglycerides 148. So as we can see her, for the past 2 years, her cholesterol levels have been elevated, and the blood glucose is now, compared to before, in the pre-diabetic range. So in this example, the doctor talks to the patient, talking about the lab results. And she said, before we discuss the findings, is there anything you'd like to discuss? I'm good. No, we could just go through those results. And of course, we could jump into it, but looking at your blood test results, your blood glucose is 110, which is in the pre-diabetes range. The patient appropriately, understandably expressed a lot of concern to this. So this is a great way to approach this, right? It's within this chat function, it's hard to have the conversation that really needs to be had. So this doctor did the appropriate job of scheduling another conversation to be able to fully talk about this issue. It's interesting, some of the things when we may be more used to certain diagnoses. My parents were physicians, so I've been used to this all the time, so I have to correct myself a lot, but it's really interesting. Or you can see how patients, like, often, like, they have a family member who had diabetes, and it's like a really big fear, and so it's really careful. I think this doctor's done a fabulous job of kind of, really providing a lot of empathy to this patient's fear about her elevated blood sugars. So in this example, she arrives for a follow-up to discuss the elevated glucose and A1C, and then we're going to see how this doctor talks to her about it.
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
So you could see how she was very concerned about this. Okay, sorry, I thought the doctor responded to that. But so this is now talking about a little bit the preferred terms. So this is people first language. So this is very important because often our patients have gone to, I have a lot of patients who go to other providers, and not their fault, again, the lack of training, or maybe they don't have personal experience with it, but a lot of language may be used that makes people feel worse and worse, right? I mean, I always tell my patients that we've really have the worst of every world. Like we've created a world that we make it incredibly easy to gain weight, and then we make everyone feel bad about it, right? So I think really I want to talk in this section how I really approach this issue in that really for hundreds of thousands of years, right? Our ancestors evolved to really find calories, eat as many of them as they can, and store them on their bodies forever, right? And that strategy worked for all of human history until 70 years ago. We still, I don't think people really have a sense of how ahistorical and abiological our current food environment is, where we have the most energy dense, addictive, and ever present calories like every second of the day around us, right? And this is why 70% of us struggle with this. And this is why out of 8 billion humans, as this food environment spreads all over the world, more people are dying of diseases of too many calories, not too few, right? So I really want to really talk about this in this section because you know, unfortunately, the world doesn't see it that way. I've been doing this for so long, like this is my conditioned response in my brain, but it's still not the dominant narrative. So when people are struggling with this every day, again, the majority of us, and then they go to seek help, unfortunately, there's still so much bias and so much guilt and shame and criticism. And really the central principle being a human is we all seek to escape from suffering. So my line is there's suffering in the world and Doritos feel good, right? So it makes sense why people, when you make people feel worse, why they would just turn to food more. So this comes down to even the most basic way of how we talk, right? Our words, our language, right? So instead of saying, I don't even say fat, but fat, chubby, extremely obese. We talk about unhealthy weight, overweight, weight problem. I personally say struggle with weight, struggle with obesity, right? People first language. And when I first like was going into my OMA Obesity Medicine Association lectures, I was like, oh yeah, that's interesting. I didn't like realize how important it was until I actually started practicing. And I think I've just conditioned myself to only speak about this issue. And, I forgot to say in my introduction, I've struggled with weight multiple times in my life. And so I can empathize with my patients. But, you know, all of this stuff, I just can't stress as much how it's the first step in establishing that therapeutic relationship with the people we're trying to help, right? And otherwise, even our unconscious biases perhaps can make it so a patient may not show up again, may not listen as much, may not take what we're saying seriously. And so this is just very important. And using really training yourself to use some of the more empathetic language, I think is very important. So again, this is the same thing. I personally like patient who struggles with obesity, but the point is the person before the disease. So this is just going more onto our unconscious bias. And, I really like to think of this unconscious bias not as like a fault of an individual, right? But these are more structural things that are basically in the air of how we are brought up talking about this, right? Like from our grandparents, and I guess I'm coming from a personal example, but like when I was around my grandpa who's an Indian, I went there, he like made a comment about my weight. And I just like, you just, these messaging is there, like from jokes that you see online to like different specials to like on Instagram to like these passing comments people make. It's just, again, all of these biases that infect our minds, that affect ourselves when we talk to people through no fault of our own necessarily. And I think having a lot of empathy for ourselves is also important in this as much as it is for our patients. But the trick is, or the goal is to be aware of some of these things, right? And I think, you know, for everyone who's attending this talk, it's by attending talks like this, understanding really intuitively how, this is such a difficult biological issue. Also, I mean, I think the number one, like no matter what someone's, view of humanity is, whether it's, personal responsibility view or like structural, structural factors that result in human behavior. I just think the number one statistic, again, I keep going back to, is that 70% of people struggle with this. If 7 out of 10 humans struggle with anything, it clearly is not a person, right? So I'm spending a lot of time in this section because I think from this core empathy and compassion for our patients, everything flows from that, right? So I think it's just really, really important to kind of really maybe question some of our underlying beliefs, perhaps, and see, how we may be talking to people and maybe if there's some optimization that needs to have there. So this is a way that we can actually talk to our patients about obesity. I am fortunate that, I am practicing this primarily, so patients are coming into me, but still, I think in a general medicine, kind of setting, I think it's really important to ask permission. And I know because of all of this, stigma and then people's reaction to the stigma, we may feel a really, we may feel a little bit reluctant to kind of talk about weight, but it's more about the how than the what. And I think really, if we do this in a way that comes from that true empathy and compassion, it comes out to our patients and our patients can see that, right? So saying, instead of like saying, I'm sure the problems you've had are all related to weight, which by the way, I've had tons of patients who have said that of they've seen other doctors, and that's kind of how it's been approached in the past. And instead saying, would you mind if we spoke about your weight and where do you think you're at? And then using the people first language, kind of using evidence-based information. I would also even correct this, like if you don't lose weight, and that's a pretty harsh thing to say. I'd say, unfortunately, having excess weight, increases our rate of diabetes. And just being empathetic and understanding. And also, I would add to all of this is that this is hard for all of us, right? And it's not like you have to come from a place where like we have all the answers and our patients don't know anything. I think it's really helpful to kind of like talk about our own struggles with this stuff, right? And whether you struggle with weight or not, because I say again, because we evolved, right? Our bodies did not evolve for this food environment, right? Our bodies want this stuff too much, and the food is made to be too addictive to our minds. I'd say whether you struggle with weight or not, everyone struggles with this food environment. It's always difficult, like thinking about, we're all in this world thinking like, am I eating too much? Did I eat too much? What's that person eating? And like this judgment of ourselves and others. And so I think really sharing some of our own struggles is really helpful and can really help relate it. And, unlike maybe some other things like, I guess like heroin or meth, which, a lot of us have not perhaps had experience with, a lot of us have had experience with just eating too much in a meal, perhaps, right? And so I think really digging deep and going into that and kind of sharing that with our patients really is the best way to establish this connection.
Dr. Gupta,
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
that does sound overwhelming. I hear you. You want to make changes for your health and your future, and I'm here to lend support. Do you mind if we talk about your weight and where you feel you are right now?
Am I going to get diabetes if I don't lose some weight? I'm not happy with my weight, but I just honestly I don't even know where to start. Ever since I lost weight a few years ago, it's just been so hard to not only lose more weight, but just even maintain the weight loss.
So again, I think that's a perfect example of how much suffering this patient is going through, right? And so if we look at her, weight journey, we start, she gained weight, then she lost a lot of weight, and then she slowly over the years gained and lost and gained and lost, right? We define obesity as a chronic relapsing thing. And I tell my patient, unfortunately, it's when you get there, it's not like it's done. This is a thing that, we have to think about and kind of like really practice our different relationship with how we approach our food environment. But I love this chart because this is exactly the way I approach, my patients. I've seen now more than 1,500 people, and I say this, and it's basically going to reflect on this chart, but you see how, a person, a body establish homeostasis with their environment, with their people, with their food environment, with their habits. And then something happens. They get a job, they lose a job, they get into a relationship, they get divorced, they have kids, their kids leave, they get promoted, they get a commute. There's something changes, right? They move, and then they establish a new homeostasis with their world. And it's just, you can see how that is so reflected in kind of this patient's journey and all of our patients' journey, really, right? So this patient, started here, and then she got laid off. And I love this pattern, because I really see this, like when something really dramatic happens. This is just anecdotal, like someone gets divorced, you do see a period where people don't, at least in my experience, have seen people like don't eat, and then something else happens. But also, like, when they start a new job, perhaps like now they don't have that time to cook like they did before, or they have to rush, or they increase their stress, so at the end of the day they just want to relax, and so they order like DoorDash more, or they like are scrambling now home they're starving, they couldn't eat all day, and they have to make food between 5 and 6, and they're munching on chips while they're making food. All of these are hyper specific because these are a lot of my patients, and you can just see, as you take people's weight history, like how all of everyone's life circumstances affects all this. And again, this is because we live in a food environment with all of this addictive crap around us every second of the day. And also, the difference between weight loss and weight gain is so small that in this food environment, it's really, really, really hard. Right. And so I think that I think this case just elicits kind of the normal variation of people's lives in this world. Right. So now we're talking about a little bit about energy, expenditure. And, I do want to say the system, and like, again, having treated all these people, is just undoubtedly more complicated than calories in, calories out. Right? The system has so many more inputs and outputs. And as you can see, just by energy expenditure, you see your resting metabolic rate. It's influenced by so many things, including your genetics, but including how much muscle you have. The thermic effect of food, that's a little bit of energy expenditure. Your NEAT, all NEAT is a fancy way of saying all the exercise. So it's non-exercise activity thermogenesis. It's basically a fancy way of saying all the movement you do that's not formal exercise. Unfortunately, in this modern world, whether you're a doctor, a cop, a construction worker, whatever you are, the majority of your job is probably sitting in front of a computer. So that part of it has another contribution to why this is so hard. In terms of exercise, we've seen there's people who gain muscle really fast, and there's people who are very resistant to it. There's people, a certain percentage lose a lot of weight with cardio. It's a minority, and a lot of people don't. And so it's just in the environmental stimuli, like what type of what type of neighborhood you live in. Is it walking? A lot of people, especially, this is relation to socioeconomic status, but unfortunately, a lot of poor communities, there's not a lot of parks. There's not a walking areas. I have a patient who I was treating who, and this is just came to my head, but it's about food. But she literally went to, like, I think it was Ralph's in her neighborhood, which was more in Inglewood, versus like the one in Manhattan Beach, and they did not sell rotisserie chicken there. Like, and it was just shocking. I know all the public health literature shows this, but just to see like a specific example of that is just ridiculous. And so I think that all of these factors are influencing, and all of these things are things to talk about. I get it. I managed a PCP clinic. I know it's hard, with the 15-minute appointments and everything. But, they're just very important to truly treat this disease. So now we're going to talk about, kind of a depressing but validating study, and this is called the Biggest Loser study. It was it's a really significant study within this world.
During one season, some of the Biggest Loser contestants famously had their metabolic rates tracked. Above and beyond the hundreds of calories less it takes to just exist 100 plus pounds lighter, by the end of the season their metabolic rate slowed by an extra 500 calories a day. The mind blower was that 6 years later they were retested and still had the 500 calorie a day handicap. So the contestants had to cut 500 calories more than anyone else their size to maintain the same weight loss. No wonder the bulk of their weight was regained. Most remained at least 10% lower than their starting weight, though, and even a 7% drop has been shown to cut diabetes rates about in half. Still, the metabolic slowing means you have to work that much harder than everyone else just to stay in place.
So, this study, I think, undoubtedly proved that this is not a willpower thing, right? So I just want to make that clear. Like 6 years later, people had to eat 500 calories or 600 calories less just to maintain, right? So think of how, depressing that is, that, people are sitting here, they're doing it, they're gaining weight, and people, I personally hate the show. I've only seen a few episodes of it, but they make people feel like so bad. When I just the one episode that's coming to my mind is like this dude is trying, he's trying everything, but he has to like take care of his kids, and then his wife and everyone's like, "Why aren't you taking care of yourself?" Because he started eating like a certain food again, but his wife's working, and and he's gaining weight again, and it's just like not a way to approach this, and it's so detrimental, and it's like not scientific, and it's very destructive to all of our patients. And this study was such an essential study because it undoubtedly proved like what people were experiencing. They're like, I'm doing everything. And they're going to people and like these providers and everyone's saying, no, you must be cheating, you must be lying. And that's not true even a little bit, right? Like everyone, you see, all my patients, no one's eating like McDonald's like 15 times a day or anything. And it's so ridiculous how we think of this as a society and what this problem really is. And yeah, this just shows it, it's a moving target, right? And that's why also like the calculated, metabolic resting metabolic rate that they do in the apps and a lot of in the personal training community is not right. Your metabolism changes. And as you lose weight, right, a lot of this stuff in terms of how much energy you do, and it makes sense again, evolutionary, because remember, humans have been around for hundreds of thousands of years, and the majority of that time, you know, they had to find calories everywhere. And so the ones who survived, the body had to get really good at surviving on very few calories, right? And so now it's just completely different. Like we've just inadvertently and now very purposefully, because of very calcified special interests in this country and now the world, now created these foods that are like right next to me. I have a 150 calorie bag of like Doritos. Like that food is like, from an energy perspective, a scientific marvel. They've stripped out all fiber. You eat it, it goes into your intestine, you absorb every molecule of that gets turned to fat. And now after you lose weight, you have this deficit of 500 calories and you eat like a bag of Doritos, it's done, right? Almost. So it's just, it's really, really, really difficult. And another reason why the only way to treat our patients effectively is to have a lot of compassion and empathy for them, and more importantly, to teach them to have a lot of empathy and compassion for themselves.
Dr. Gupta, this is similar to a question that came in online. What do I do for my aging patients to calculate their BMI as they shrink? Does BMI need to be adjusted, or can I use their max height?
I saw that question. I think it's, again, we're just using this data as surrogates of what we're trying to find. I think it's fine to use their current height or maybe their max height, and you can use kind of whatever metric. I mean, I think that really, I think using other measurements like waist circumference and ideally, body composition is just a more accurate way to measure health risks. But it's kind of all about like, what is the point of any test, right? Like again, Harvard gave me very good training, but it was always like, when you do a test, what's the point of it, right? Like, what's your intervention? And I think that's what you think of a BMI. Just take the max and min and see, if you want to like see where their risk factors is. But again, the numbers of the difference in how the formula works, those numbers, like if someone it goes from a BMI of 25.4 to 24.6. It's not that much of a difference in how you would change the management of that patient, right? So I think that just really using it as one piece of data, then using it as one piece of data versus making it
Yeah,
the end all
sure.
be all as a
So
goal.
I work on film sets. I put up together all the different props and everything like that. It can be pretty physically demanding. I do work up a sweat as I'm setting it up, but once I'm done with that and the set is set up, I will sit down for most of the day. So as far as food goes, the studio usually provides us with meals, but they aren't really super healthy. Oh, and I also like to take walks with my boyfriend on the weekends. They typically will be about 45 minutes, maybe an hour long, depends on the weather. Um, but honestly, just thinking about finding time to exercise more just seems really overwhelming.
So I think that, that speaks to a lot of our patients' experience appropriately, right? And I think our patients, with kids, with work, with jobs, right? It's easy to say, oh, she should just get up an hour early or whatever, but that's not accurate to it, right? So I think all of our interventions have to be corrected, and this is what this is what I describe as like the biological compassion approach, have to be corrected for people's time, energy, and desire, right? So in this patient or in any patient, you start where they are, right, and what they're ready for. But for her, for example, I would say, okay, like if that was one of our goals initially, I don't actually focus on physical activity at the beginning, but ultimately, I would, if we're talking about that, I would say, okay, let's start on the days you have off, right? Because if you can't do it when it's easy, how do you do it when it's hard? So start with the days, and then what do you like, and what have you done in the past, and what have you liked in the past? Because like, if people hate the gym, they don't need to go in the gym. Like, it's not going to work if you don't like it, right? So I think really, really spending time and figuring out what vibes with people's actual lives, and not making them feel bad about it, because you don't know what another person's experience is, right? Honestly, like, you don't know what their life's like. You don't know all the suffering that they have to go through, all the other things. And I think, like, really, coming from a place of just that empathy and compassion is the only way into this. And patients can see that, and that's the only way that you can actually help people. And that's the point of why we got into this thing anyways. Okay. So, some considerations. This is a slide that, kind of really kind of elaborates on kind of some of the stuff I was talking about. You know, you know, asking, open, like, leading questions, communicating intention to help. Um, I think, like, figuring out what is actually going on in people's lives, explaining, the nature of the problem. I'm using weight neutral terms, all of this stuff. This is kind of like the stuff that I was kind of saying, but it's really just, starting from that place and really feeling and that compassion towards our patients, I think, is the core of it. And then, yeah, creating SMART goals, right? I like to say, like, when I'm talking about physical activity specifically, okay, so like, what time would be the most ideal time you could work out, right? Sometimes they would say, I need to wake up an hour early. And I said, okay, so what do you do in the morning? And they say, like, I get up, I have to make my kids breakfast, I have to check my emails, I have to do this. I go, no, 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 that's not the right time, right? There's too much mental load, right? We have to see that, we're not, robots, right? And there's a reason why, like, the AI has gone so much farther than robotics, because, like, to move and do things in physical space is actually a lot of mental brain power. And so we got to see, when is it actually, like, again, like, helping the patients see through that self-compassion empathy, when are the right moments in their lives to start doing this. I think the SMART goals are fine. Coming with measurable stuff. I do think that it's kind of patient dependent and how some people respond to certain things. Some people respond to more like a concrete plan. Some people respond to like a lighter touch. I have a patient that, she was an athlete when she was younger, like in her 19s and 20s. She had put a lot of pressure on herself to maintain a certain weight, work out a lot and stuff. And then now she struggles with weight like several decades later, but she was resistant to anytime she had to work out, she had a lot of negativity around it. So I said, okay, just set up a space in your room and just sit there for like 10 minutes or 15 minutes, like at the ideal time compared to what she said. I said, just go on TikTok, don't do anything else, and just like wear your clothes. And then so that was like, gave her that freedom to connect with what she liked about physical activity rather than all the negativity and everything. So I think, really these are important ways to kind of treat our patients. So let's get this. So in this example, the patient lost 5 pounds, and the doctor said, "I can see you've been working hard," and all this stuff. Okay, and I think introduced to medications. So I think we're going to go over medications more in the next talk a lot, but just to introduce, I really like to say there's a pre-GLP world and a post-GLP world, right? So these medicines are kind of the older generation. I really like, I'm taking this from this cardiologist I heard at an OMA convention, but he really talks about the history of obesity as a history of hypertension. And really historically, like FDR, our president, 40s, World War II, died of hypertensive emergency, a hypertensive stroke with a blood pressure in 220s, and it brought like hypertension into the public consciousness. And in 50s, there were all these like dangerous antihypertensives. You had to go to a specialist. And then we had like the Framingham studies of like the 60s, 70s, and all these new medications that came out, safer, effective, and now like every single doctor like treats hypertension, right? So it feels like obesity initially, there were all these medicines, there's a lot of testing, different things, of course, we know like fen things have been, taken off the market because of dangers. And then we came out with things that work, right? And then, the next step is showing cardiovascular improvement, which we have. And we'll talk about that in the next study, the next slide next week. But, these first generation anti-obesity medicines still have a place. I use them mostly as adjuncts, but we have phentermine, which is FDA indicated for short term for 12 weeks. And the only reason for that is because it's cheap and no one has studied it for afterwards. Although I've seen good meta-analysis that shows that when phentermine actually gets you to lose weight, you actually do improve your blood pressure, heart rate, and everything. I like to start with a very low dose at 8 milligrams. Go to 15. I rarely ever use higher doses, and I use them kind of more as, again, that adjuncts. Like if someone is choosing to do some intermittent fasting, maybe use a little bit of 8 milligrams in the morning to get them to, that first spot at 11 a.m. I think it's a great medicine. It was one of the fens of the fens. The other one is fenfluramine. That's the one that was associated with the valvulopathy. But phentermine, it's a tired and true medicine. It's cheap. I think it works. It works really well in the right cases. But there are a lot of weight loss clinics that are not doing it correctly. Orlistat, no one uses this. It causes like way too many GI side effects. They are coming out with the next generation version of these type of molecules, which may be better. Phentermine and topiramate, I don't use this anymore. Topiramate, I think the doses you got to use it for, cause too much brain fog, too many side effects. And so it's also, this shows why phentermine is, because phentermine/topiramate, brand name Qsymia, is indicated for the lifelong treatment of obesity versus phentermine is not. And that's because Qsymia is a pharmaceutical, brand name drug. Then we have naltrexone, bupropion, Contrave. I like this medicine actually a lot. So I think, should I answer these questions? I'll answer the questions after. Okay. So then we have Contrave, which is naltrexone and bupropion. I like using this medicine a lot, either individually or in this combination form. It is interesting, as you can see, how bupropion initially, we used it for depression, but then smoking and cigarettes and tobacco, and naltrexone we use for opiates and alcohol, and both these molecules we use for food. So it shows how these pathways are so conserved. And then we have liraglutide, our first generation GLP for diabetes known as Victoza at a higher dose Saxenda, once daily. It was a revolutionary molecule, but multiple famous study. There was a big famous New England Journal of Medicine study comparing liraglutide to semaglutide, and sorry, it would have been more dramatic if the slide worked, but okay. So I think it's almost like 7:25. So these are, you guys can read these. These are some of the complications and things to watch out for and adverse effects. But let's move on to the next. Okay, we're just gonna skip these. Okay, so now we're talking about semaglutide and tirzepatide. So, these medicines, these second generation, are able to produce greater than 10% weight loss and safely produce greater than 15. So both these medicines have greater than or equal to 15% weight loss. These GLPs that are once a week, we got 10 to 16 with semaglutide. And so, we see how, the amount of, these are kind of just the data showing the different amounts of weight loss with these medicines. And you can see with semaglutide and tirzepatide, we're getting 10 to 16, 16 to 23. When that first New England Journal of Medicine study came out of semaglutide, it was just, it was a phenomenal study because no weight loss medicine has ever done anything close to that. And there's been so many in the early 2000s, there were people who were looking at leptin and they were looking at all sorts of different things and nothing worked. And again, there's a lot of nihilism around science around obesity. And then we discovered these GLPs, which have just been an absolute game changer. And there's even more molecules that are coming out that can compete with weight loss surgery. Eli's coming out with one in 2 years. And we'll talk a lot more about those medications and the studies and everything next session. But which of the following are true regarding the semaglutide and tirzepatide? Of course, it's actually greater than or equal to 15% weight loss. And so how they work, how I describe them, they're secreted by the intestinal L cells, but I say that normally as food moves down our GI tract, our intestines, pancreas release these fullness hormones called GLP, GIP, CCK, amylin. There's a bunch of them, and they're actually going to be therapeutic targets as we keep moving forward, but they go to our brain, they decrease our hunger, they slow our GI tract and make us feel full. Unfortunately, our natural fullness hormones are completely overwhelmed by our modern food system. And instead, we have created these molecules that emulate these and have the therapeutic effect of them at higher rates to cause decreased hunger, decreased craving, and increased satiety.
GLP-1
They have a lot
and
of other factors.
GIP. The GLP-1 is a hormone produced in the small and large intestines. It is released in response to food intake and stimulates insulin secretion and suppress the glucagon secretions, but only when there is glucose in the bloodstream. The GLP-1 has also other beneficial effects. It slows the absorption of carbohydrates, resulting in low blood glucose levels after meals. It also causes loss of appetite, and animal studies have shown that it can promote the regeneration of pancreatic beta cells and improve the survival of existing beta cells. The GIP hormones are produced by cells in the upper small intestine, and they are released when glucose comes into contact with these cells. Like GLP-1, the GIP acts on pancreatic beta cells, where it stimulates insulin secretion and also appears to promote beta cell proliferation and survival. GIP may complement the action of GLP-1 receptor agonists. In preclinical models, GIP has been shown to decrease food intake and increase energy expenditure. Therefore, the combination with a GLP-1 receptor agonist may have greater effects on markers of metabolic dysfunction, such as body weight, glucose, and lipids.
Okay, So, GLP and GIP, which is this tirzepatide, brand name Mounjaro, and for weight loss, the stupid name of Zepbound. And it talked about how it has both those molecules, and it thought to enhance the effects of GLP actually, as well. So I'm going to save this, like a lot of this talk for next time, and we'll get to questions. So I have right here. Doesn't our willpower have to be around eating what your body needs? Doesn't this mean they have to lower metabolic rate and didn't need the extra calories to start with? My basal metabolic rate will be lower than I would like. Um, I guess I don't understand what you mean by did they need that or not? I mean, there's many reasons we eat, right? And I think if you put humans in this world, it is very easy to eat. And given that 70% of us struggle with this, it shows that this is not like an individual factor. I think that, I'm not sure what perhaps, if the question is, kind of talking about this, but really, if someone is like working two jobs as these kids, or even like has suffered from anxiety, depression, or even eating like a lot of fast food because they're struggling with certain emotions or feelings or thoughts or different things, and they stop by here, like I get that's not because that they are like weak people or that they don't have the strength, that to like not do that, right? Those are things that need to be addressed and dealt with, right? Like, so if someone, a lot of times, like people may need a lot of stimulation, like they're like feeling anxious all the time. I've struggled with anxiety my whole life. I know what that means, but I see all my patients, or someone might have ADHD or needs to be stimulated like that all the time, right? Or they have like, some trauma, and they, anytime it comes up, they want to have a craving to eat something, right? So I think that, you know, I don't know what it means that what your body needs or not. I think that, everyone's body does not need as many calories, like I guess in a way that all of this food environment provides us every single day. But it's just not a helpful formulation, I think, to say like, oh, you don't need that many calories. Why are you eating that many calories? Because, again, so many of us are. Instead, it's a much more, I think, productive to say, okay, let's figure out the reasons why this is happening and let's address those reasons. The second one, I understand there are multiple factors that contribute to obesity, but in the end, does it come down to balancing energy in and out of our bodies? That is true, I think, but it is that balance, but there's other factors that go into it. I think it's helpful to remember that how we, sorry. Okay. The next thing is about the multiple factors that contribute to obesity. Um, so, you know, I think that, with the calories in, calories out kind of thinking, is that how we measure calories are actually in a device called a bomb calorimeter. And so what you do is you put food within this bomb calorimeter, it blows up, and the amount of heat that is generated is the amount of kilocalories, shorthand calories. Our bodies are not bomb calorimeters, right? Like when you eat, food goes down and it's influenced by different factors, like beyond just what the macromolecules are. For instance, if you eat food with certain vegetables, you absorb less of it, versus if more ultra processed foods goes into your body and it gets absorbed right away, right? And then otherwise, your microbiome is another thing that influences it. You might absorb more of a certain amount of food, like you might absorb more calories from what you eat compared to another person, depending on how your microbiome is influencing it. Additionally, there's hormonal factors, like when people go into menopause, that there's nothing that slows your metabolism down, like menopause. The amount of muscle tissue you have, sleep, irrespective of calories, can influence it. Stress, chronic stress with the chronic cortisol can cause it. So I think the inputs are way more, right? And so I think that that's kind of the model of this that I think is more empirically proven, and also just more proven with my experience with my patients. Okay. Anything else? And I apologize. I didn't mean to like I don't know if I was being offensive to anybody or anything. I'm just very passionate about this, so I apologize if I was.
All right. Well, thank you so much. If you do need credit for this activity, this is the QR code to scan, and feel free to fill out that evaluation. We'll get you credit. Thank you, Dr. Gupta. I'm looking forward to next week for sure. If anybody had any last minute questions, please feel free to put them in the chat. Great. All right. Well, thank you very much for joining us.